Hello, everyone. Thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Abby Espinosa, the Program Coordinator at CSCLA, and I'm honored to welcome you to this week's webinar titled A Guide to the End of Life, A Nurse's Perspective. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you would like to learn more about our services or watch past webinars, please visit our website at cancersupportla.org. Before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar. You may, however, enter your questions into the Q&A feature found at the bottom of the Zoom window at any time. Questions will be answered at the end of the presentation. We may not be able to get to all your questions today, but we'll get to as many as possible. And to introduce today's speaker, Sarah Lowe is an oncology care coordinator with 14 years of experience in inpatient hematology-oncology, inpatient hospice, and nursing education. She has published articles on a wide variety of topics, including interdisciplinary collaboration, nursing quality indicators, and geriatric issues. Sarah is passionate about supporting patients through the entire care continuum. It gives me great pleasure to welcome today's speaker, Sarah Lowe.
Thank you so much. It's such an honor that all of you came to spend your lunchtime with me today. So let me go ahead and share these slides. Okay. There we go. So today, I'll do about the guide to the end of life from a nurse's perspective. Once again, my name is Sarah Lowe. I am an oncology care coordinator. I've worked for the last 13, 14 years now in oncology. I love oncology so much. And I actually think that the end of life is actually a very special time. This talk is going to be considering a lot about symptom management, especially as a nurse. That's what I'm very interested in, and how our patients just have the best life they can possibly have. This talk in itself is not going to focus so much on things like advanced directives, physicians' orders for life-sustaining treatments, also known as POLS, or the end of life options. Those are all very important topics, but there is a really great talk that CSCLA hosted from Karen Warren that is available on YouTube for life choice, discussing end of life choices. So I would encourage you all to look at that. And of course, if at the end there are questions, I'm happy to answer what I can about those topics as well. The goal for today is to discuss the role of palliative and hospice care, as well as their very distinct differences. We'll also review some symptoms that may occur during advanced stages of cancer and the interventions that may help alleviate those symptoms. We also are going to go through an overview of the general timeline of symptoms that occur during weeks, days, and hours before the end of life. There'll be no graphic photos in anything in this PowerPoint, but of course, if anything is triggering, please just go ahead and get off of this talk. This will be filmed and available, and then we'll open it up to Q&A. So I would love to recommend to all of you a very wonderful book called A Beginner's Guide to the End by B.J. Miller and Shoshana Berger. In particular, a good portion of this talk will correlate with two chapters in that book, Dynamic Duo and Symptoms 101, along with, of course, my own input from my own experiences. And I wanted to start with this quote, which is, There is nothing wrong with you for dying, but you'd never know it from the way we talk about death. We actually call it a failure. Her health is failing. He failed treatment. If you believe what you read, the entire enterprise of aging is optional. Eat kale, drink red wine, walk 10,000 steps every day. If we can't beat death, then clearly our character or will or faith isn't strong enough. But what about all those fighting words? Beating death, defying aging, the war on cancer, all battles we're sure to lose. Next to birth, death is one of our most profound experiences. Shouldn't we talk about it, prepare for it, use what it can teach us about how to live? We don't mean to suggest that you or anyone can take the reins and control how all of it is going to go. Part of the challenge is tempering that need for control. Death as a subject is not easy, and dying is not painless. We make no promises to the contrary, and we encourage you to run from anyone who does. But we believe that this book, and I like to think this talk, will help dying be less painful and more meaningful. So this talk is really centered around looking at the realistic options that we have. But often when we talk about realism, especially when it comes to the end of life, it sounds like it's something very dark and dire. And yet, I actually have a very different perspective. And this is a personal philosophy of mine from my own experience personally as well as professionally. So this part isn't necessarily evidence-based. But what I truly, truly believe is that one of the best things we can do when looking forward at advanced disease and all the symptoms that come from that time is to start from a point of realism. And I will say that I actually am somebody who believes miracles are possible, which is kind of a funny thing to say when I'm asking everybody to please embrace realism. But what I mean by that is that we start from a place of what do I know? What do experts say? And what can I gain from them? What do we know in terms of science? We start from there. We start from a place of acceptance of, okay, so like this is what these experts think. Are the things that I'm seeing in my body. And just coming from that point of acceptance. It doesn't mean that miracles are not going to happen. But starting from that point of acceptance, I find often can make a huge difference. That's not necessarily an easy thing, and neither is the next that I'm going to ask, which is that the next thing is to embrace flexibility. Embrace that fact that we have to try things in different ways, that a lot of things we can't necessarily fix, or we can't necessarily change things that suck, that we can't erase all of our suffering or the suffering of the people we love, but that often different ways of looking at things and being willing to try new things and to consider different things can be really powerful. We all have a very intense need to hold as much control as possible. And a lot of this process, like was said in the last quote, is about letting go of that control. And you'll find, I think, that when you combine realism with the potential for flexibility, that you get a really fruitful optimism. That a fruitful optimism that I like to contrast against what I do sometimes see is you might have heard the term toxic positivity. Sometimes people want so badly to harness the power of positive thinking that it becomes almost like a tool for avoidance and denial, and at times can become very harmful. But what I see is that when we can combine realism with flexibility, we have the opportunity to be really optimistic, but in a way that's actually really fruitful. So I'm going to talk about some of the tools that I think that we have us on this journey. And two things we have are palliative care and hospice care. They go together like cookies and milk. And there is an abundance of research now that shows that people who receive palliative and hospice care experience less depression and anxiety. And it also now shows through abundance of research that palliative and hospice care doesn't shorten life, that it can even prolong life. That was a big concern that many people had in the beginning as these specialties were rising. But while palliative and hospice care were kind of created at specialties at the same time and had a lot of supporters advocating for both, they are actually very distinctly different. And that's going to be really important to discuss. So, what is palliative care? So, palliative care is specialized medical care for people living with a serious illness. This type of care is focused on providing relief from symptoms and the stresses of the illness. And so, because the focus is on symptom management and quality of life, palliative care can be connected. It doesn't have to be at a more advanced stage. If you have a diagnosis of a serious illness, then this is something that can potentially be started at any time. But because, like I said, palliative care and hospice were kind of rose up in the ranks at the same time, and there's such a thought in so many people's mind that if I go to palliative care, does that mean that I'm at the end of life? A lot of different hospitals and departments have actually rebranded, including Cedars-Sinai. So we now call our department supportive care medicine to really emphasize that symptom management piece. And it really can be connected at any time. There was actually a period at Cedars where as soon as a patient walked into our bone marrow transplant service, we would connect them to supportive care medicine. We can't do that anymore because we don't have the bandwidth for that, but you can understand the concept, which is we can start early. And we also have research demonstrating that patients connected to palliative medicine have less interruptions in their treatment schedule, both in getting the severity, the dosage intensity, that's the term I'm looking for, the intensity of the dosage and the timeline that the doctors are prescribing. So a doctor might say, hey, for your cancer, this is what I recommend. I would like you to be on this chemotherapy regime. It's going to be for 4 or 6 cycles. They're each going to be 21 days apart. But because of some of the symptoms, patients are going to often have to dose reduce, get less of the medication, or even take medication breaks or holidays because the symptoms are just too much. What we found is that patients who are connected to medicine and are getting a lot more symptom management support actually tend to get the treatments that the doctors want them to get. And of course, we see that the correlation of them just having better outcomes or the outcomes we hope for if they're able to get the treatments. Yes,
sorry, I'm just gonna interrupt you really quick. Your audio is lagging a little. If you want to turn off your camera just during the presentation, so hopefully that can help.
Yes, of course.
Yeah, and then you can turn your camera back on during Q&A.
Yes, thank you for letting me know. That must be so confusing. Okay, come on.
Thank you.
There we go. Okay, let me go. Okay. Okay, so the goal is to improve quality of life for both the patient and the family. So that holistic piece is actually a part that we also really, I personally really value when it comes to palliative care, because we are more than just our disease. We are all the parts of us, and our families are so important, and our caregivers as well. So you can imagine, if you think of palliative care in terms of symptom management and improving quality of life, if you think about it that way, then it's probably not surprising that palliative care is actually a very important aspect of hospice. Because at the end of life, we really care about symptom management and quality of life. We want our patients to have the most meaningful and enjoyable time with their families. Um, so you will see that it's going to be an important part of hospice care, but they are actually very distinctly different. So let me talk a little bit about hospice. So hospice is called, this is the definition, physical, spiritual, emotional support for those with a life expectancy of 6 months or less, with the goal of increasing comfort and provided where you live. So there's nothing magical about that 6-month life expectancy. It's just an arbitrary number. Patients, anybody can be enrolled in hospice indefinitely every 90 days. It was just a number that our politicians thought made sense. It is considered its own insurance coverage. So you would be technically disenrolled from your insurance and enrolled into the hospice. But everyone who has insurance coverage is supposed to have hospice as an option. And the other thing to keep in mind is that you can disenroll at any time. So if at any time you feel that it's not the right fit, then you can just go ahead and disenroll and go back to your original insurance and to the care that you were receiving. Something to keep in mind that does become something challenging for many, many people is that hospice provides some really great resources, and we're going to discuss those resources, but it does not replace caregiving. There are places in America where they have hospice homes, where patients can actually go to a hospice home and receive care towards the end of life. Unfortunately for us in California, because our property taxes are so high, that's not really an option for us. The hospice houses are just not able to function. I do know of 4 hospice homes that are in more rural areas in California. And if that's something you're interested in, please take a look at that early. But typically speaking, caregiving still needs to be provided by somebody in the home, a family member, say, or a friend, and hospice provides support. It is meant to be holistic, so hospice providers can also support the family, and tends to be very good about considering the entire family's needs. I do recommend considering early. It's just helpful because none of these things that we're talking about are magic bullets that are going to just make everything great for us. And getting to know different agencies, what you're comfortable with, what resources are there, can be really great. Also, because unfortunately, most people wait unnecessarily long before they go to hospice. So 1 in 3 patients will enroll for a week or less before they die. And for some people, that's the perfect amount of time. But for so many patients, they actually could have really benefited from all of the services much earlier. The other thing to keep in mind is that you do need to be prepared to forego curative treatments. And so that is, I think, one of the reasons most patients that I have worked with, once they have gone into hospice, are finding that they are where they want to be and they continue. But at some patients, they're like, okay, this is not the best fit. I actually want to try a certain treatment. Then that's when they might consider disenrolling from hospice and going back to what they were having previously. So it is important to remember to be prepared to forego curative treatments, but there's a difference between what we consider curative treatments and treatments that are meant to support your quality of life. And improve symptom management. So an example of that is a patient who might have some back pain. They might be considered for a kyphoplasty, but a kyphoplasty has like a 12 to 18 month recovery period. With a life expectancy of 6 months, that's actually probably not going to be a great use of our resources. Instead, why don't we just focus on getting their pain under control so that they can just be as comfortable as possible? That versus a patient is having a UTI. Well, the UTI comes with pain. Maybe it causes confusion. There's all sorts of things that infection causes. Let's give them antibiotics and treat that infection so that they can be comfortable. So those are the considerations that are made. So what are some of the things that hospices can provide? A hospice doctor, a hospice nurse. Typically, the patient will spend more time with a hospice nurse and less time with the doctor. The doctor tends to more oversee, but also is available to prescribe what's needed or order things that are needed, tends to make things move a little bit more quickly than typically in our hospital systems. A hospice aide is somebody who can provide some assistance with like bathing or simple things in that way. A social worker or counselor, chaplaincy services, volunteers are sometimes available to buy groceries or do other things in the home as well, even just to provide some company. Physical, occupational, speech language therapist. So depending on your needs, they will tailor that to you. A grief counselor is available for up to 1 year after someone passes. It's a really great service that a lot of families and utilize. Basic supplies and durable medical equipment. Things become much, much easier to get to our patients in a timely fashion and getting covered by insurance when somebody's on hospice. So that's a big blessing. 24/7 telephone support. Respite stays are sometimes possible for the caregivers. Prescription support, around the clock nursing care for a day or two. Unfortunately, this isn't something that I have seen available commonly, but it is sometimes available, and that would be typically closer to the end of life. What I see much more often is, say, we're seeing signs and symptoms that somebody's more imminently dying, and then the hospice nurse comes by much more frequently and maybe even starts an IV to provide some pain medication if the patient is no longer to take oral medication. Okay, so those are some great things that hospice can provide. Let's talk more about symptoms, some things that we want to think about. So one thing that we're going to think about is that most discomfort is treatable. Fixable is not always true. We're not always able to fix, but alleviation is often possible. And so we often have to look at things from a different perspective. We're not necessarily able to fix. Sometimes we can, and we will try. But if we can't fix it, that doesn't mean we can't help. The other thing we want to think about is acute versus chronic symptoms. So acute are symptoms that are brief and severe. If these symptoms occur, then you want to let someone know. Maybe going to the ED will be helpful. Now, chronic symptoms are going to be over time. They persist even though we're trying our best to mitigate them. And as much as it can be hard to say, they often don't need an urgent response because going to the ED isn't necessarily going to move the needle. And this is where sometimes we can start feeling hopeless. But on the other hand, with a chronic symptoms, you also get time. You get time to get to know, get time to experiment, and time to be creative. And that's where we get those different colored glasses, a different perspective, that there are things that we can do. And it is also important to remember that if you're thinking about an incurable condition, An incurable condition is going to come with incurable symptoms. We're going to expect that there will be some things that are not going to go away. And that's something that we need to expect. But once again, we're going to go back to the fact that we can't get rid of them doesn't mean that there isn't anything what we can do. And that's where I say you are the best judge, because you are not a statistic, you are a person. And just like I can safely assume that nobody in this audience has ever met someone with 2.5 kids, even though that is supposed to be the average of how many kids people have, 2.5. You are not that statistic. And if something works for you, then we are thankful. We don't judge that. We are thankful. And one of the most well-studied phenomenons in science is the placebo effect. And we have some fascinating research suggesting or demonstrating that for a certain proponent of patients who respond to a placebo, that their body is responding with real physiological changes. So there was this fascinating study where patients were given either opiates or a dummy medication. And for the patients who got the placebo medications, there were patients who were actually producing their own natural opiates in response to this placebo. And so that's why the studies and the way that the authors and the scientists were discussing the studies was fascinating. They actually called it triggering your body to heal itself, which I thought was wonderful. That's just to say, if it works for you, then that is wonderful. It is also important to remember that medications can cause other symptoms, and we have a terrible problem where we prescribe a ton of medications and we don't usually unprescribe them. And medications themselves, so valuable, and yet it gets complicated and can cause lots of side effects as well. So that's where, just keep that in mind. And our palliative care and hospice doctors tend to be much more in tune with paring down medication lists. And that's something that I definitely invite you all to discuss with your teams when you are trying to navigate. There are also lots of different alternative treatments. Our Western trained doctors, we're fully aware that our healthcare is not considerate of everything that is possible, and that we don't have all the training. And 80 to 90% of people use alternative treatments, but only 30% tell their physicians. And this is where I say, please, please, please tell your oncologists, tell your doctors about the alternative treatments that you are considering or trying. I have actually personally never met an oncologist who was really adamantly against alternative treatments unless there was a very good reason to be so. If anything, a lot of doctors were more just like sort of dismissive, just like, oh, okay, we don't have research for that, but whatever, that sort of thing. But the reason why I ask you to please tell is because there are some things that we do know. And an example is that I had a patient who we had a very difficult time getting her through her chemotherapy treatments and stem cell transplant. And then she went home and she had a special delicacy dish, which was like a not fully grown chick that was raw. And she came back with raging sepsis. And that was an example of something where 99% of the time would have been perfectly fine and appropriate. But in this one situation where she was extremely neutropenic and immunosuppressed, it actually almost killed her. And that was something that, we did have information on. So let's talk, I'm going to go through some symptoms that can occur during advanced cancer and the end of life. And one of them is going to be anxiety and depression. Anxiety is an overall sense of worry or fear or difficulty concentrating, like restlessness. Depression can be described as lethargy, having no interest, feeling hopeless. The truth is, a certain amount of anxiety and depression is actually considered normal for, for somebody going through an advanced illness. And it's also normal in sort of in ways that we often don't think about. Things like boredom and frustration that come with the long waits and the long the systems that we're in, the fact that it's like a full-time job having to deal with an illness and all the appointments and things, and we sometimes inadvertently end up cutting ourselves off from the things that give us joy in life. Also, of course, from unmanaged symptoms, which are increase our suffering. So many things. And meds can be incredibly helpful. But sometimes so too can be things like just putting yourself in front of the things that you care about and reconnecting. So we want to consider all the different possibilities. And here are some herbal and non-pharmacological options, and of course some medication options. And I will say that this is a very wide net that is being cast here. Some of these options are not as well studied. These are things that for some people is more anecdotal or more like passed down, where people have done this over time, but not necessarily has an abundant amount of research. But they are on the list because some patients have found them helpful, and because the likelihood of them causing harm is very small. So if this works for you, then like we said, we don't care. What we care about is you and your wholeness and happiness. And so just to explain, that's why this is a very wide net that's being cast. So some things we can do. Counseling can be a wonderful option. Distraction, meditation, breathing exercises. I've heard of patients doing something called couple breathing, which was a very lovely way to connect as well, where two people breathe at the same time. And allow their heartbeats to beat at the same time as well. Can be very calming. Guided imagery, physical exercise, which, by the way, besides the fact that it's free and can be done just to whatever your ability is, it has as much a rate as medication as improving anxiety and depression. And it's free. Energy healing like Reiki, music therapy. There's vibration, music assisted therapy as well, animal assisted therapy, massage, acupuncture, craniosacral therapy. This is a gentle hands-on technique that uses a light touch to examine membranes and movements of fluids in and around the central nervous system. And it relieves tension. This is one of those things where, people feel controversial about this in terms of some people feel that it's pseudoscience-y. But once again, I have a patient who finds it very helpful. I think that that's wonderful. Please do it if it works for you. Unfortunately, this isn't one that is covered by insurance usually. But there are also essential oils like lavender, citrus, clary sage, bergamot, ylang-ylang, and herbs like milky oats and seeds. And of course, we have medications that can be so helpful: antidepressants, benzodiazepines, psychostimulants, cannabis. All things, of course, that do need to be done under the supervision of a physician. And especially when it comes to cannabis, which can be a wonderful tool, but unfortunately, because it is an unregulated market, please, please, please use the community. Use the cancer communities, what people have known, the places that they trust that can be growing safely and giving advice, because not all cannabis is made equal, and different strands actually have different properties. And yes, of course, like any of these other medications, there can be risks because these are, medications. So you want to be doing them under the guidance of a physician. Confusion. Um, Confusion, another term we often use is delirium. So when someone is unaware of themselves, we call that person, and then place or time. And it's actually a lot more common than people think. And it's actually very common in the hospital when you're in an unfamiliar environment and when sleep-wake cycles are disrupted, which is everything to do with the hospital. But also can happen when you're at home and you're anxious and having trouble sleeping, when there are so many things you have to consider. You're being woken up because of pain or other things. And there's all sorts of different sources: infection, neurological conditions, insomnia, uncontrolled symptoms, medications, liver kidney disease. Um, and the confusion can often be waxing and waning. So there can be some confusion and then, perfectly reoriented again, and then a little bit of confusion, and it can go in and out. Um, there is one called sundowning, which is when confusion gets worse at night. Um, we can also see that confusion can also be expressed as hypoactive, so less emotive and doing less movement. And what we see is that family members often are the ones to notice confusion or vague personality changes. And also sometimes patients don't really want to um, disclose that they're recognizing that sometimes they're getting confused. And what I want to say is that there really is no reason to be embarrassed, because this is actually very common. Um, and we want our doctors to know, and our healthcare teams, we want to know, because if there are sources that we can uncover, then we can actually make a big difference. And even if there isn't something very clear for us to be able to change, we can still improve the situation. So what can we do? Huge thing: support sleep-wake cycle. Can be so hard, but some very basic discipline, consistent things can make a huge difference. And even when someone's in the hospital and you're being woken up at all terrible hours of the night, things like keeping the curtains open so you get as much natural light as possible during the day, having times where you are turning off as much unnatural light as possible, having putting devices away at a certain time. These things can all be supportive and can make a huge difference. Reorientation, we can do things to help patients reorient themselves, and you can set things up as well. So that's like being near a window with the curtains open so we can see the daylight and the time passing, having a clock so someone can reorient themselves. If you're a family member, just have a casual conversation and talk about familiar people and familiar things, current events, but don't respond with any judgment or strong reactions, no matter what is being said. You just go along and go back to what you're saying, and that's a very gentle way of reorienting someone. And also surrounding them with familiar things. There are ambient essential oils that have sometimes been found to be helpful, like rosemary, vetiver, citrus, basil, craniosacral therapy, animal-assisted therapy, acupuncture, and we do have medications as well, like antidepressants, benzodiazepines, psychostimulants, and cannabis. But we always dive into those very carefully, because they can also have the reverse effect. So please definitely go with what your doctor recommends. Constipation, and I am talking very fast, so so excuse me here, but constipation is a huge one. Almost everyone tends to underestimate the impact of constipation, and constipation can cause pain, nausea, loss of appetite, shortness of breath, fatigue, and delirium, and it can be a medication side effect. It can also be a side effect of immobility, nervous system dysfunction, and dehydration. And we say that no matter, we're always going for the goal of whatever your normal bowel habits were before you got sick. You want to keep in mind that even if you're eating less, your body is naturally sloughing, and that sloughing needs to come out. Um, So we want to act quickly. This is my own personal recommendation, is that because I don't want my patients to have any more problems than they already do, I say, hey, if you have been not having bowel movements and you have been escalating by, taking laxatives and drinking well and doing what you can, and you still haven't had a bowel movement at the end of 5 days, I say, oh, pull out an enema. You can buy one from the drugstore if you feel comfortable doing it, or take yourself to urgent care, because nobody has time to deal with that and have more problems. Some things, please drink lots of water, warm water with fresh lemon or lime juice, chewing on fennel seeds, mobilizing, exercising, abdominal massage. There's a technique where you start from the left, you move, you want the movement of your bowels moves from right to left, but you start with massaging on the left like an I, and then you turn it into an L on the top, and then you turn it into a U, like I love you. And that's a way to help stimulate that movement. Acupuncture, acupressure, reflexology, prune juice, biofeedback, and other relaxation, homeopathy, flaxseed oil, herbs. And there are teas as well with like senna, medications, laxatives. There are lots of different kinds. So it is best to just run things by a doctor at some point, because we want to do the right fit. With laxatives or fiber, you just need to make sure you also, besides discussing with the doctor, really make sure to drink enough fluid. One that I personally tend to gear towards is polyethylene glycol, also known as Miralax, tends to be a bit more gentle than some other options, and is easily available. Prokinetics, lubiprostone, misoprostol, methyl naltrexone, tegaserot are some other things that doctors can do. Diarrhea. Some treatments actually actively encourage diarrhea, I will say. Like there is an infection called C. diff where we actually need you to get it out of your system. So just to keep that in mind. But this can, of course, be very, very distressing. You want to think a lot about skin health when you're dealing with diarrhea as well. You might need to get, Vaseline, diaper rash cream, those sorts of things to just support your skin. And sometimes we need to change medications because medications can cause diarrhea. But there are different things we can try, like slippery elm, aloe vera juice, carob powder, probiotics, fermented foods, bland foods that are going to be less irritating for our symptoms, electrolytes and fluids because we need to keep you hydrated, chamomile and peppermint tea, oversteeped black tea, and then there are medications as well. So dry mouth xerostomia, unfortunately, does become common towards more advanced stages, particularly at the end of life. And then we go for warm tea and lemon. Mouthwash is a tricky one because I don't personally like to do a mouthwash unless it has an artificial saliva component like biotin, because mouthwash often has alcohol and can be drying. Having said that, if it works for you, I'm not going to complain. Please keep going. Increase the fluid intake, acupuncture, lip balm, like I said, artificial saliva products, tart candies, lozenges, ice chips, and certain foods as well, and swabbing the mouth with glycerin, a very simple one that can be really helpful. There are a few medications, although not a ton. Fatigue, this is when you rest and you still feel exhausted, and there's lots of different sources for that. Surprisingly, one of the impacts, one thing we can do is exercise, sleep hygiene, like I talked about, social engagement, breath work, yoga, massage, energy healing, caffeine, essential oils, animal assisted therapy, craniosacral therapy. And we also have medications we can consider as well. So please be sharing this with your doctor. Hiccups. The only thing I will say with hiccups is that fortunately it's not common, but it's also not something we see. It does happen. And all I will say is that there's actually things we can do and medications we can try because it can be distressing. So please don't give up hope if this happens to you. We have itchiness, also known as pruritus, lots of different sources for this. And we have different things that we can try. We actually have light therapy. That's UV light therapy can actually, in certain cases, depending on the source, emollients and moisturizers, lotions, skincare, avoiding irritants, cooling environment. Sometimes we would say have our patients put their topical lotions or things in the fridge so they get that extra cooling sensation. We have medications as well. We actually have a lot of different options, so we would like to try them all. Loss of appetite, cachexia. So food is often an emotional topic during the end of life, and a cachexia is involuntary weight loss. And what we see in advanced disease towards the end of life is that the body is unable to handle outside nutrition and it starts to use its own inherent stores. And it actually becomes a part of the process of the body shutting down and being really efficient to the very end. And it's actually a sign of death coming. It's not actually causing death, but I know it can be incredibly stressful because it feels like, well, my loved one needs to eat. But this is where we say we give some of our suggestions of what we see can be helpful. We look at repositioning in positions that optimize swallowing, makes it less uncomfortable, more comfortable. Adding fat to the diet. We say at this time, eat whatever you want. You want that ice cream? Like anything that goes in is good. You sometimes actually swallowing and eating can be distressing, then go chew, savor, and spit. You don't have to swallow it. Sometimes we can cook for scent or symbolism, just enjoying that experience with family, even if you yourself don't feel like eating. Eat for pleasure, small portions, smooth textures, and sweetness tends to be easier. We ask that you please, if you're with family, encourage but don't force. And there are certain medications we can try to stimulate appetite. Nausea, so many sources, including a lot of other symptoms that are not cared for, can cause nausea. And we need to keep in mind that our mucosa runs from our mouth all the way through our esophagus, through our intestines, and out the rectum. And all of that is going to get affected with a lot of our cancer treatments. So what can we do about it? There are a lot of, we can try some herbal and non-pharmacological interventions. Ginger, peppermint, chamomile, fennel tea, sparkling water and grapes, acupuncture, acupressure, anti-nausea wristbands that you sometimes see in pregnancy. And we have a lot of different medications that are trying to attack the nausea from all different angles. So there are a lot of different things that we can try. Pain. We have both mechanical sources of pain, and then we also have the neuropathic pathway of pain. And so when it comes to cancer, either of these can be stimulated. And in particularly, I'll mention that neuropathic pain is one that some of our treatments and our cancers themselves cause and need to be treated a bit differently. Also, we see that serious pain towards the end of life, we do at that time really see the need for targeting that with medication. Other things we go for as well, but medication can become that really big source of support. So here are all of the things. I won't go through all of these lists because we're running out of time, but I just want to have this list so that you know that there are options. Please know that even if we can't get rid of the pain, there are often things that we can try. Shortness of breath, dyspnea, can be really distressing, and your oxygen saturation could be high, but that doesn't mean that you don't feel short of breath. And it's like this feedback loop between anxiety, because feeling like you can't get enough of breath triggers anxiety, and anxiety itself makes shortness of breath worse. So what can we do to help? There are going to be mechanical things and emotional things that affect our shortness of breath. Ambient airflow can be very comforting. Positioning, there's this tripod position where you lean forward. That's really helpful. And actually, my mom was in that position for most of her advanced stage of cancer. Breath work, guided imagery, meditation, energy healing, psychotherapy. Even if we can't attack some of the muscular skeletal parts, like let's go for that neurological pathway, that emotional pathway. We're going to attack this from every angle that we can, and we're going to try medications. Skin breakdown. Unfortunately, when you're not moving as much and as your body starts to decline, skin breakdown becomes more likely. We really have to watch for those pressure points. We want to inspect daily, keep that skin healthy, try to prevent as much as possible, more than anything. Okay. Oh, taste changes. So what I'm going to say with taste changes is that one of the things that we can try to do is optimize the taste functions that are there. Our taste functions sometimes at the end of life, and because of treatments, they get wonky, and it makes it hard for us to want to eat. But what we can do is work with what we have. If something tastes too sweet, we can go ahead and try to add some sour to counteract that. Does something taste too flat? We can try sour, we can try sweet. Something's too sour, we try adding sweet. Too spicy, we add fat, add sweet. Too salty, add sour. Too bland, add sour or salt. Too bitter, add sweet. So you'll see, I said, so we're going to counteract this and work with what we have. Sweetness is one of the very first senses of taste that we have. And so there are also theories about sweetness being also one of the most primitive, something that we can go back to. And maybe one of the last ones to go away. So, if nothing else, that's something to try in that area. Okay, I'm going to run through symptoms at the end of life. So weeks before death, some things that are common. Of course, everyone's situation is different. I'm not saying this is prescriptive. I'm just saying that these are some of the things that we tend to see. But social withdrawal is actually quite common. We see increased sleeping, decreased appetite, like we discussed, weight loss, bodies becoming very efficient, fragile, easily damaged skin, general pain. And then we really focus on comfort and pain management during this time. Days before death, we often see drops in blood pressure, changes in skin color, cooler hands and feet. So the body is sort of starting to wind down, fewer bowel movements and urination, decreased appetite and fluid intake. We hear something called the death rattle. Does not happen to everyone, but there is a increase of secretion sometimes, and that can make the breathing sound like there's this sort of raspy, rattling sound. We will say that we don't have any evidence that the death rattle actually bothers patients. For more than anything, we see that it tends to be most uncomfortable for the family or loved ones. So we do, if we're in the hospital, we will sometimes treat that. But we don't have any evidence that it causes any distress itself. But we do see that when the death rattle appears, that the average time of death is 23 hours. So that tends to be a harbinger, like, okay, so it's coming. And actually, increased deliriums, increased hallucinations, increased of maybe recitations of things that were from childhood. We see more of this becoming more common. And on the day before death, so getting closer to the time of death, sometimes we see a sudden burst of energy that fades. If this happens, please enjoy it. Please make the most of it. But just know that this does happen. And sometimes what we see is that families get so excited and start planning for the future, but it's actually a part of the dying process. So just an FYI about that, but please enjoy it if it comes. skin becoming increasingly mottled and blotchy, further drops in blood pressure, inability to swallow, less urine, increased restlessness, labored breathing. Um, and there's this type of breathing where there's like long breaks, and then there's it's like agonal breathing, which I'll discuss more hours before death as well. Um, Hours before death, glassy, teary eyes that may be half opened, cold hands, weak pulse, increased hallucinations. So there might be confused statements being said. Sleeping and unable to be awoken, breathing is interrupted by gasps or may stop entirely. That sort of agonal breathing, where there's this gap, and then all of a sudden, a big breath, and then a gap as well. So these are sort of the signs that we tend to see. And then how do you know when your loved one has died? Well, cannot be awakened is one, of course. Breathing stops. So there's different ways you can check. Hand up to mouth and face, listening in, feeling for the chest rising. We can look for pulses as well. Our eyes and our mouth tend to naturally open after someone dies. And so this is one thing that you can think about is in the hospital, we actually would tie a ribbon around patient's head to keep the jaw shut, and we would also close the eyes. That way, when rigor mortis sets in and the body's muscles sorts of freezes, that the patients would freeze in a position that was just more comfortable for everyone, where it was peaceful with the eyes closed and the mouth shut. Um, so yes, sorry, I raced through that, and I'm so happy to answer questions if anyone wants to stay past the time. But I'm just going to end with this quote that you matter because you're you, and you matter to the end of your life. We will do all we can not only to help you die peacefully, but also to live until you die. Because as much as all this talk has been about dying, what this is actually about is living, and how to make the most of that. So I'm going to go ahead and stop my talk here.
I have one final closing slide. So if anybody would like to learn more about Cancer Support Community Los Angeles, please feel free to visit our website at cancersupportla.org. And if you would like to get a copy of today's slides or would like to request Sarah's contact information, please email us at info@cancersupportla.org, and we will be sure to send that over. And lastly, we just wanted to share a little bit more information about an end of life program that we will be doing beginning next week. It is an online workshop series, and it'll begin next week every Wednesday until April 2nd. And each session will cover a different topic. So if you'd like more information or would like to register, please scan the QR code on the bottom right-hand corner. And if you have any questions about the series, please feel free to email us or call us at that number that is shown below. And once again, I want to thank Sarah. Thank you so much for being here with us. We really appreciate you sharing all of your knowledge and staying a little bit over with us to answer a few of the questions we've had. And I want to thank all the attendees who came here today and got to watch this amazing webinar. And we hope to see you all at the next one. Thank you.